All right, and now I have the pleasure of turning things over to Robin Bowman and to John Wiener, two of our clinicians who are a part of the National Spina Bifida Patient Registry. They work very closely with us. John actually is on our board of directors as well too. And so with that, I'm going to go away. Welcome, John. Welcome, Robin. We're glad to have you. Thank you so much for joining us.
Oh, terrific. I will go ahead and get started. Thanks again, Sarah and everyone for inviting us. John and I were going to talk about the National Spina Bifida Patient Registry and the UMPIRE today. Well, our only disclosure is that for both of us, John's at Duke and I'm at Lurie Children's in Chicago, is that for both of us, our centers participate in the National Spina Bifida Patient Registry and for the UMPIRE studies and receive grants from the CDC for our participation. The National Spina Bifida Patient Registry originated when back in 2005, the SBA sent a survey around to all of us in the Spina Bifida centers throughout the US. And basically what that survey identified was that there was a variety of different treatments that were going on throughout the US, and that the care that you would get at one clinic may not be the same care that you would get at a different clinic. And so it was at that time that the SBA, in conjunction with the CDC, recommended that there be a registry that was started in order to document the care, and so that we could look at what was going on and try to improve the outcomes. And so it was at that time that Congress authorized the creation of the patient registry. Currently, the registry has a little over 10,000 participants. The registry started in 2008, and at that time there were 9 centers that received funding. 11 years later, we have 14 centers that are participating and that are funded, and we have 8 centers that are participating and are not funded. And we're currently on a 5-year funding cycle. The participation of any patient with spina bifida is voluntary, and the data that we gather is obtained on a yearly, annual basis when they return for their clinic visits. So what's the purpose of the registry? Is to identify the healthcare and the clinic practices that are associated with the best outcomes for the kids, the patients, the young adults that are living with spina bifida. How do we collect it? Is that it's a questionnaire. When the registry started in 2011, there were 20 questions. Currently, there are 43 questions with 3 supplemental for skin breakdown. So it has expanded significantly since it was originally started in 2011. And then in 2014, we added the UMPIRE, which is a prospective management from a urologic perspective for the newborns and infants in order to preserve renal function long term. And if you look at this map of the US, you can see the variety of centers that are participating. The blue means they're participating in both the registry and the urologic protocol. The red means they're participating in the registry only. The green means they're going on their own, that they're unfunded. And the purple means that they're participating in the UMPIRE. And so you can see it's spread throughout the US. So why do we collect it, and what are we collecting? We're collecting the patient with spina bifida, their characteristics, the interventions they've had, the diagnostic studies they've had, and we're looking at the outcomes, and we're wanting to use this data in order to compare the outcomes through different clinics to see where areas where things are going well and where areas where things are not going as well as at other centers, so that we can standardize the care for all children and young adults with with spina bifida to improve the care nationally. So in order to do so, we have to evaluate what we're doing. We have to evaluate our outcomes. And that means publishing what we have learned so far so that we can share with everyone the knowledge that we've gained, that we can use it to improve our care for all with spina bifida, and that we can improve or increase our level of science behind our care, and that we can use that to go to Congress, to go to the federal government, to prove to them that this is a worthwhile investment, that indeed the outcome for those living with spina bifida can be standardized nationally, and we can elevate that care. So the first study that was published in 2013 was this one, and it basically showed that we can do it, that we can track our data, that we can have multiple centers involved, we can ask the questions, and we can overall, we can as a whole work together to document what's going on. So this study was just testing the feasibility. This was just showing that indeed, as a group, we can work together and get this job done. The next study published was a couple years later in 2015. It was published in the Journal of Pediatrics. Again, from the first 10 clinics. And it was on a little over 2,000 patients, and the average age was about 10. And it showed that those participating in the registry, about a majority of them were in the pediatric age range. So 85% of them were younger than 18 years of age, and that about 50% of them were ambulators. Or for those with open spina bifida, it was a little less than 50%. And it shows that bowel bladder impairment was a significant issue for those living with open spina bifida. The next paper, published a couple months later, was on the sociodemographic attributes, again published in Pediatrics by Michael Schechner. And what it demonstrated is that the older individuals were actually more likely to be continent, but to also have a higher incidence of pressure sores or ulcers, and as they aged, were more likely not to be community ambulators. And interestingly, it showed a disparity that non-Hispanic Blacks were more likely to be incontinent or less continent. And that all of the outcomes, there were variation amongst the clinics except for community ambulation. A few months later, there was in the Physical Medicine and Rehab, there was a publication on pressure ulcers, which again was from all 19 clinics. It was for a little over 3,000 patients. And what surprisingly, it showed that at a yearly visit, about 20% of our patients reported some type of skin ulcer, which was very surprising to many of us. The risk factors associated with that was urinary incontinence, the lesion level, so that if you have a higher level or worse function and you relied more upon a wheelchair, that you are a higher chance of having a skin ulcer. The presence of a shunt, if you'd recently had surgery, which makes sense that you would be less ambulatory, and for those of the male gender. A subsequent paper in Physical Medicine and Rehab looked at factors associated with mobility. And this data was, again, from all 19 clinics and included about 2,600 patients. And it showed that community ambulation was associated with those that didn't have a shunt, those with lower level of lesion, and those that have not had no history of hip or knee contracture surgery. And you can see here that ambulation, as you'd expect, was higher or more prominent in those without open spina bifida. My last couple of papers that I want to review before turning it over to John to go over the bowel and bladder studies is a couple papers that were published recently in the Journal for Neurosurgery in the Pediatric section. The first was on Chiari decompressions. For both studies, there were about 4,500 participants. For the study reviewing the Chiari type 2, it showed that about 9% of our participants had undergone a decompression, and that the decompression or the risk for needing decompression was associated with higher lesion level, and that the younger children were more likely to also require a tracheostomy tube. When looking at the data, it also demonstrated that over the years, that since 2005, there's been kind of a shift away from Chiari decompressions. On the hydrocephalus front, again, it was the same number of participants, and it showed that about 80% of the patients with open spina bifida had a ventriculoperitoneal shunt, although there was a variation amongst centers with a range of anywhere from 72% to as high as 96%. And again, it was shown that the higher the lesion level, the higher the risk for needing a shunt. And when looking from the shunt, however, there was no change in treatment patterns before or after 2005. Okay, John, I'll turn it over to you.
Thanks, Robin. And actually, if we go back, let me see how. Sorry. So just looking at this study, there are over 4,000 participants. And before the Spina Bifida Registry, you look at papers and there may be 200 or 300 patients in a paper. And just the experience at maybe Lurie Children's or at my hospital. And it's not very helpful to scientists when you're just looking at something at one hospital. There's no registry like this in the world, and it's really fantastic that we're getting information. It may not seem like we're moving the needle that far, but we really are because there's so many patients in the registry. I spent a lot of time worrying about bowel and bladder continence, and this is a paper that came out looking at bowel management in adults because there's just so little out there. I think the biggest paper was from Robbins Institution at Northwestern. It was 250 patients. And so here we have over 5,000 participants, 26% were adults. Again, the largest study was 225 adults. And you can see that bowel continence is improved as patients get older. They learn how to take care of things and learn how to work with their bodies. And so of adults, this is one of the more interesting things, and nobody's really reported large numbers of spina bifida patients' socioeconomic outcomes. So we found that in the registry of the adults, 14% were working full-time and 18% were working part-time. That together is about half the what you'd expect in able-bodied population, which is about 65%. 21% were students and about 28% were permanently disabled. Of those 25 and older, about 20% had a college degree. And again, that's about half of able-bodied. But a lot of people think that if you have a kid with spina bifida, that they're not going to become an adult. And here we have 20% have college degrees. And that 27% had gone to school after high school. Of those that were 25 and older, bowel continence was not associated with being male or female, whether you had private or public insurance, what type of spina bifida you had, or where your lesion was, or your educational attainment. The thing that was most statistically associated with bowel continence was employment. So again, this is really important information because we use this to talk to parents of 2-year-olds saying, we need to work on these bowels so your child will, get a job one day. We also, my partner, Jonathan Ruth, is very interested in disparities of care. What's the variation? We actually found that there is a big variation in surgery rates at different hospitals, and we need to find out why that is. A similar paper looking at bladder management in adults. Again, about the same number of people, about 5,000. About 20% had undergone bladder reconstructive surgery, but you can see that rates vary from 12 to 38% among the 20 plus clinics in the registry. Again, looking at variation in bowel surgery and combining that. I'm not going to go through the details of every study. This study in Pediatrics, which is really one of the biggest journals in those of us who take care of children, these are really beautiful data, and this was working with our statisticians at CDC. This is how many people have stool continence by age and by diagnosis, and the red circles are open myelomeningocele, and the blue circles are the non-open types of spina bifida. And as expected, bowel continence is better if you have closed spina bifida, but you can see that it goes up with age, but really doesn't cross 50%. We need to do better. It is better in those with less severe forms of spina bifida, but we've got a lot of work to do here. Urine continence, pretty much the same thing, reaching about 50% for those with open spina bifida or myelomeningocele, and better for those without open spina bifida. Pressure sores. Robin talked about the paper, the first paper on that, and you can see here the red circles are, again, open myelomeningocele, and as patients get adult size, look at how common pressure sores are. That's something we all need to work on. If you have non-myelomeningocele or closed spina bifida, then you're less likely to have pressure sores. Ambulation. Green is community ambulator, and you can see as patients begin to get to be adult size, those that are community ambulators goes down, and those that are using wheelchair most of the time, in red here, go up. This was a paper that came out from headed by Kathy Smith, and just looking at differences in continence rates among individuals based on ethnicity, and they found that Hispanics were more likely to have bowel incontinence. It was pretty much even among all other ethnic groups in terms of bowel and bladder continence. And then this last study was, just came out in March of this year, where David Chu, who was one of my residents here at Duke and now works at Robbins Hospital, led this study. And we think that every patient should be getting an ultrasound every year to look at their kidneys and get blood work to make sure their kidneys are working well. And looking at the best centers, I mean, those that participate in the Spina Bifida Registry are some of the best spina bifida clinics in the world, and still only 62% are getting proper surveillance. Keep rolling it the wrong way. I'll talk a little bit about the UMPIRE protocol. UMPIRE stands for Urologic Management for Preservation of Renal Function. We really don't know the best way to manage the bladder at birth and how we continue that. And the CDC, through the hard work of Judy Thibodeau, who was at CDC and is now at SBA, really led us to begin this study at birth. And so in December 2019, this first paper came out, and currently we have 391 participants in the registry. The oldest are about to turn 5. We just got funded for another 5 years, so we'll carry this out till they're 10, and hopefully we'll keep getting funded to continue this to see how these people do into adulthood. Keep rolling the wrong way. I don't expect you to read this, but this is a very specific protocol of how we're going to manage the bladder of children born with open myelomeningocele. And we all agreed to it at these 9 centers. We're just now starting to get data. This was published about a year ago. And it turns out that most Children with spina bifida are born with fairly normal urinary tracts. Only 4% had concerning findings on an ultrasound. 16% had reflux into their kidneys, but most of those were mild, and 8% had an abnormal renal scan. So basically, over 80%, close to 90%, are born with normal kidneys, and our job is to make sure those kidneys stay that way. So when you think about the UMPIRE protocol, it's trying to keep bladders and kidneys safe. I'll turn it over to Robin now.
Thank you. So this is what medical progress looks like. Currently, we have the largest database for spina bifida in the world, and the first prospective urologic protocol that, as John said, has run for 5 years and has just been funded to run for another 5. It's a lot of data. We're proud that we have more than 10,000 patients with spina bifida as participants, but obviously we need many more to include everyone living with this disease. What these scientific publications prove is that the registry and the protocol both work. They're teaching us new information, they're helping us standardize the care, and they are having an impact on the care that we're giving each and every day. But it's crucial that we continue this and that we continue to define what is associated with the best outcomes. Let's see if I can advance. John, are you able to advance?
No, I cannot.
Oh, there, it just advanced. Thank you. Oh, well, maybe not. Oops, now it advanced twice. Excuse me. There we go. What these publications prove is that the CDC, in conjunction with the SBA, we're making big differences with very small amount of federal support, and that the tax money really is making a difference for the care of those that are living with this very complex congenital anomaly, this complex disease, so that your tax money is encouraging more and more people to devote their lives to taking care of those living with spina bifida. And it's a hotter topic. It's bringing it to the forefront of everyone's mind. And there's more discussion occurring at scientific meetings, which is a good thing. Let's see if I can get it to advance. There we go. So how's the registry and UMPIRE studies translating into making or improving the care for those living with spina bifida? As we just talked about, we're spending more time talking about education and employment. Our urodynamic studies have been modified to meet higher standards, and that we're standardizing the care across many centers for those infants born with spina bifida. And there's a lot more powerful data to share when we sit down to talk to expectant families or to parents of newborns and young children, that we can share with them that long-term, nearly 3/4 of patients are on catheterization, that unfortunately currently less than half of our patients are continent, and that about 1/4 of our adults have undergone bladder augmentation. But as John said, there's a disparity in that there's some centers that are doing more augmentations and other centers that are not. And we're still trying to figure out why there's a difference there. We also now ask about skin breakdown. As you saw several slides ago, that this is a significant issue. When 20% of our patients that are coming in annually are reporting skin breakdown, this is a big problem, because it's not just the skin breakdown, but skin breakdown leads to infection, which can then lead to the need for surgery or, God forbid, amputations. And so it's very important that we ask about it and that we have effective ways of treating it. That we are addressing bowel issues early and more thoroughly. And at least in John's clinic, they've been able to add some additional nurse practitioner to help support this, and that we're doing the same thing each and every visit and trying to do the exact same thing and ask the same questions and inquire about the same health issues in every center that's involved in the registry, so that we can track all of these outcomes more closely. We're also now, as you saw, checking creatinine and monitoring the kidney function more closely. We've talked about how skincare is regularly addressed. We're trying to study the variations amongst clinics and why at some patients at some clinics get some care where it's a different type of care at a different clinic. That needs to be standardized across all centers across the US. So currently our best estimate is there's 166,000 Americans living with spina bifida. That's twice as many than are living with sickle cell disease, and that's 4 times as many that are living with cystic fibrosis. So that's a huge number. We working together, as you saw the presentation, that fantastic presentation by Will and Megan, working together, we can make a difference. Again, when you're talking to your congressman, remind them this is the largest database in the world on those with open spina bifida, and it's the first prospective urologic protocol. That, interestingly, that we've been able to build up so that we have over 10,000 participants. We want many more participants. The difficult thing at our individual centers is that as we're adding patients and we're adding questions so that the questionnaire, what we discuss, is more than double, the funding hasn't changed. So that even though we're taking care of many more patients, we're including many more in the registry, and we want to include even more, and we want to find out even more information, we're doing it with the same amount of money. And so we really need more funding. We need more funding in order to continue with the current sites, and we need to add other centers. Eventually, it would be great that no child, no adult with spina bifida were in the US and not part of the registry. And so this is what it looks like, is we need you to go to them and to ask for money, to seek money, to send it to the CDC so that we can put that money into the research and care needed for those living with this very complex congenital illness. And I want to thank you for listening to us. We are more than happy to take questions if there's time for that. Thanks, Sarah.
Sure. Thank you guys very much. I really appreciate that. We've got about 15 minutes. I'd like to start by asking a question. First of all, I've seen the slide before, and it is the best representation of what we try to do with Teal on the Hill that there is. So thank you guys very much for putting that up there. I was hoping it would show up. I just wanted to kind of ask a question in general that I think might help clarify things for people. You guys have been involved with the registry for quite some time, and you have been in the room when there have been those long meetings discussing things. And I don't think people realize that no 2 hospitals, when we first started down this road, no 2 hospitals were really doing things the same way. And I'm not talking about just doing tests, but they weren't even doing tests the same way before we started down this road. So can you all talk just a little bit about some of the changes that you've seen in the practices of hospitals based on involvement in the registry?
Sure, I can pop in, and then I'm sure John has thoughts on this. Even just in, the urologic protocol, even in our own center, prior to the UMPIRE, it was very much dependent upon which urologist was helping us care for that child. There would be a bit of a variation in the testing obtained or the timing of the testing. And when you have that variation, even at a single center, let alone at multiple centers, it makes it hard to assess the outcome. And if you can't assess the outcome, you don't know what's working and what's not working. So you have to standardize the care in order to assess the care that's being given and the outcome, so that we can, continue to do what's working and throw out what's not working.
Yeah, it's so much more complicated than you would think. I mean, I think people could understand why one neurosurgeon might choose to revise a shunt and another may not, that surgical decisions, but even simple things are so difficult. How do you define if somebody is continent or not? Who's asking that question? The patient may give a different answer to their doctor versus the research coordinator versus a nurse. So we're learning how to ask those questions better. And things like, from a surgical standpoint, there are some patients that urine goes to a bag. That was kind of standard in the 1970s. We as surgeons think that's a failure. But for some patients, they may think it's better because they're not in diapers anymore. So it depends who you're asking the question to. So we're just learning how to ask questions better and do it the same way at every place. And I think we all start speaking the same language.
Thank you. I think that just kind of helps people understand. We talk a lot about things like outcomes and interventions and all of that, but at the heart of this, it's really trying to standardize what doctors do and when they do them, I guess is one way, and how you ask the question even is important. And I think that's part of, go ahead.
Oh, well, people may think, well, why we already know what's the best operation? Well, we can't know what the best operation is. We can't agree on how you ask somebody if they're continent, or how do you ask somebody, what their neurologic function is.
So there's a question that really doesn't relate to this, but they're asking about a clinic for adults in Western New York. My suggestion is that you contact the National Resource Center. They can help you with clinics. And there's another one about Midwestern states with no participation in the clinic. Do they have a spina bifida clinic that could potentially be added, or no spina bifida clinic at all? If no clinics at all, then how do researchers hope to try and gain data from those states? So there are a lot of clinics that are not in the registry. So just because they're not on the registry list does not mean there's not a clinic. I'd suggest you go to the website where we have a complete listing of clinics to look at your state and see what's available. But if there's information about your state and it's not being included in the registry, that's part of the reason we're asking for increased funding, because currently CDC does not have the staff to be able to even onboard clinics that are willing to pay their own personnel to be a part of this registry, because the registry has now gained enough influence and impact that there are institutions out there that are willing to be a part of it without federal funding. But we can't onboard them and we can't include them because there's literally not the bandwidth at CDC in order to process that, because that does take some of CDC's time. It's not just poof, you're on the registry. There's a lot of work that goes into that, and you have to be trained and you have to be onboarded and your information has to be vetted, and all of that has to still occur to make sure that we're getting the best quality information out of it. You can't do that without people. And right now, there aren't enough people at CDC working on the National Spina Bifida program. So therefore, that's the reason we're asking for more money. So that's a big part of it. What should I do if I believe I was part of the registry until 2012 because I was at one of the children's hospitals in the blue categories, but once I aged out, I may not be part of it? You are absolutely correct. You probably aren't. And I know that this is something that CDC is grappling with. And again, it goes back to that funding issue. It's something that we've asked them to look into about what do we do with people who age out of the clinics, that follow-up. And if they're not going to a clinic that's in the registry as an adult clinic, then we lose that information. So it goes back to that age-old question, no money, no mission. no more money for CDC. This is something we can't do. So this is a good reason. This is a story that helps to say, hey, we need more funding for CDC for this.
And indirectly, Sarah, I think there are young trainees that Robin and I trained. One of them, for example, was a resident here in Durham and now is on faculty at Robin's Hospital, who he was going to go into adult urologic cancer research. And he got turned on by spina bifida research and saw what we're doing in the registry, and he decided to become a pediatric urologist, and now he's getting paid to do spina bifida research. And there's a real buzz among young urologists to do what we call transition care, to start taking care of the young adults as they age out of children's hospitals. So an indirect benefit of the registry is that it creates enthusiasm to take care of people with spina bifida as they age. And I think we're seeing a lot more young people who are interested in that. In the old days, there just weren't doctors interested in taking care of adults with spina bifida, or not many.
Here's another question. Are outcomes for individuals with spina bifida who do not have a spina bifida clinic in their area and are receiving healthcare services from general practitioners and specialists being tracked by the registry?
The registry is clinic-based, so it has to be a clinic to collect information. And it has to be a clinic that checks all the boxes. So the only information in the registry is from really top performing clinics, which is a problem. The question's a fantastic one and one we want to answer. We want to prove, we think that we're doing all this work that we have better outcomes. We don't know that for sure, but we're looking for ways to answer those questions.
If spina bifida is the #1 permanently disabling birth defect, what is the reason for the lack of medical resources for adults with spina bifida? Care and research seem to be primarily aimed towards pediatric and transitioning care. There seems to be very limited focus on adult concerns.
If you look back at old papers, only about 10% of children with spina bifida live to age 2. And this is true of a lot of birth defects, that in the 1950s, most people didn't survive to school age. And so for that reason, all the doctors taking care of these problems, like spina bifida or cystic fibrosis, were pediatricians or pediatric surgeons. So that there were no adult doctors that took care of these patients because there were so few adults with these problems. And so we've just been playing catch up. And I think the registry is helping us bring that to light, showing the problems and getting people involved.
I would say that this is not only the spina bifida community's concern, but most congenital conditions are in the same situation for that very reason, that medical care improved so greatly that life expectancy improved, but nobody thought about what was going to happen after the fact and how we were going to care for people. And I think we've got a long way to go in terms of educating the general medical community. The specialists that deal with spina bifida on the pediatric side get it. They've been involved knee deep in this for so long that they understand it, but their adult counterparts don't. And so we've got to become advocates. That's part of the reason that we spend so much time working in those medical societies, trying to find a foothold to build that communication so that we can start educating those specialists and even generalists. And we're trying to get to primary care physicians too. But the fact of the matter is that takes money and it takes time. And we're a small organization trying to do a lot of different things at this point in time, but that does not mean we're not trying. It's just not going to be an easy fix, because it's not just simply going out and getting a single doctor who's willing to treat someone, but you have to look at things like reimbursement costs and all kinds of complex issues, because we are not an easy fix by any means. Our issues take time, and they mean that doctors have to spend more time with our patients. And so they need to be reimbursed for that. And so it's not just a simple fix of finding somebody who says, yes, I'm willing to, but really we have to start looking at the underlying causes that might prohibit physicians from actually taking on that challenge too. And all of that takes a lot of time, energy, and money. Does not mean we're not going to get to it, but it just is going to have to, it's not going to be something that we can fix overnight by any means. And we have to do it in conjunction with other organizations because it's not just our issue. It's an issue in general for people with conditions like the ones that we represent.
And Sarah, last year I had the great opportunity to go to Capitol Hill with some of the patients and families, that's where I met Will Dickey. And I think that we opened a lot of eyes that this isn't a children's problem. This is, we think there are more adults in America living with spina bifida than children. So I think this is a great opportunity when you're talking to people on Capitol Hill to make them realize that this is not a pediatric problem any longer.
Right. There are several other questions. We have just a few minutes, so I wanted to see if I can knock out some of these pretty quickly. A question about that their state doesn't have clinics. Is there a way that patients can participate even if their clinic does not? Unfortunately, at this point in time, there is not. It is clinic-based, as John said, although we are trying to look at other ways to get information out of people who are in areas that aren't covered by the registry at this point in time. But again, time and money plays into that. A question about is the registry raw data available to larger scientific communities to stimulate more research? Fact of the matter is you can partner with any one of those institutions that's in the registry and have access to the data, but your entryway is through one of the participating clinics, if I understand correctly. Is that correct, John and Robin?
Yes.
Yeah, the CDC,
Okay,
it's their data. We're collecting it for the CDC. But a great question, and if you've got a question, yeah, come to one of the centers and talk to us, and we can come up with an idea and pitch it to the CDC.
Yep. What is meant by urodynamic studies are now modified to meet higher standards? What's an example of the higher standards?
There's really not a lot known about the right way to do, or let me restate it. There's not a good agreement on the right way to do urodynamics on a newborn. In the UMPIRE study, we found that one place was filling the bladder 5 to 8 times faster than the rest of us. And so we're just trying to define the proper way to get the best information on conducting a urodynamic study. Again, just simple things like how fast do you pump fluid into the bladder? That's the easy part. The harder part is how to find agreement on those squiggly little curves. But we're making some progress on that. We're doing some stuff with machine learning.
I'm laughing because I sat in on some of those conversations, and boy, were they doozies. A question about addressing clinics that are recognized as clinic care partners but are not a part of the registry. That is correct. Clinics may also connect with SBA through the Clinic Care Partner Program. They agreed to meet 10 different standards that are listed on the website. And we're not really collecting data from them at this point, but the fact of the matter is they are looking at quality improvement projects and a few other things that relate similarly to the registry. And again, somebody's reminding us that they've grown up, that they're adults. And yes, we believe 65% of the people living with spina bifida are adults. And Mike, I will see if I can get this information to you about the infographics. It is up there. I'm not sure what the problem is, but we'll see if we can get that out to you. And are we coordinating data with groups like APD for HCBW? And I'm not quite sure exactly what they're asking. So I'll reach out to you about that. And if you don't go to a clinic but see a urologist at a clinic location, no, you're not included in the registry. If you have to be a participant in one of the clinics that's in the registry to be included in the registry. And I think that's the end of it. And we're only 2 minutes over our time, so that's pretty good. So John and Robin, thank you very much for joining us today. We appreciate it. Robin, it's great seeing you again. We didn't get to see you at the end of the clinical care meeting, but take care. Bye-bye.
Thank you. Bye.
All right, and so now we are going to adjourn for a brief break. We'll be back at 3 o'clock on the hour. So everybody go grab something to drink, take a stretch, get up and walk around, and we'll see you back here at 3.